So let's start off talking a little bit about that legislation, and we've got some good news, which is you've really found some great results from that 2014 bill, which now you're trying to expand and extend. I'm wondering, Senator Stabenow, can you talk a little bit about the shortcomings that your bill was trying to fix in mental health care?
Absolutely. Well, first, thank you to the Washington Post and to you. I also want to give a shout out and thank Glenn Close, who has, for the third time, come in to help us with this movement and move it forward. So thank you so much. And to my partner here, Roy Blunt, we couldn't do it without the two of us working together. So bottom line, we don't treat mental health and addiction services the same as we treat physical health services. We like to say we want healthcare above the neck to be the same as healthcare below the neck. And we have at least 1 in 5. We were debating 1 in 5, 1 in 4 people that are impacted by mental illness. Either way, it's a big deal. And less than half of them will get treatment in a year. And we know that the #1 cause of death in this country is drug overdose for people under age 50. So this is something we have to address. And what we propose and what we're now moving forward with is to mirror the very successful effort of federally qualified health centers in communities that can accept private pay, public pay services, but are qualified for full Medicaid reimbursement because they provide quality services. And so a community can be designated. It's not just grants. It's not enough to have grants. We welcome grants as a supplement, but we want to be integrated into the healthcare system. So behavioral health centers are doing the same thing. We were able to get support to start the funding for 8 states for 2 years to demonstrate this works. We have 8 states that are getting the full funding like a health center. We have seen psychiatric crisis services, 24-hour services set up in the community, so someone's not going to the jail, someone's not sitting in an emergency room for hours or maybe days trying to get help. And it's transforming those communities. And so we've added additional resources. Now the next step is we want to take this more broadly across the country.
Could you give a few examples of some of the kinds of mental health services that people haven't been able to access, particularly people on Medicaid, that your bill's trying to address?
Well, I think we just think any mental health services you need to be accessed and need to be accessed like you'd access any other health care need. No 14-day limit, no 21-day limit. Just treat mental health like all other health. It's no more complicated than that. In our state, where we're one of the 8 states that were part of the pilot, I think we have 200 different locations in Missouri where people can go and they know that their mental health issue is going to be dealt with just like any other health issue that they have. And as Debbie said, Paige, one of the things we're trying to do here is really create that body of evidence that shows the impact on your other health issues. You know, if this is 1 out of 4 or 1 out of 5 adult Americans, imagine all of the other health issues of that 20 or 25% of our population. Those issues are much more easily dealt with logically, and if your mental health issues being dealt with. So I think we're going to show not only is this the right thing to do. We went to the floor the last day of October 2013, the year we started this effort. It was the 50th anniversary of the last bill President Kennedy signed, which was the Community Mental Health Act. And we sort of went through that bill together on the floor. And many of the things that probably should have been closed got closed, but almost none of the alternatives that that bill envisioned 50 years later were out there as an easy access to whatever mental health problem you need. And again, I think we're going to be able to show in this study, and one reason we want to expand it for another couple of years is to get even a larger body of evidence to show that this is not only the right thing to do, everybody gets that, but it's in the immediate space of healthcare, the financially smart thing to do as well. And I believe we're putting that information together in a way that's going to be pretty persuasive that doing the right thing is also financially the cost-effective thing.